now by Dr. John Elefteriades from Yale, who all of us know has done tremendous work in with our knowledge of aorta and aortic surgery. And I thank you, John, very much for joining me. We won't talk about the aorta, may come back to that, but tell me a little bit about your vision of the hybrid OR of the future.
Yeah, I think that the technology of radiographic imaging and the computerized management of those images is just exploding with potential. And in particular, what's most exciting is how the machines of the present and near future are able to integrate information from CAT scan, from MRI, from angiography, and put it all together in real time, so that one can be advancing a catheter and see the relationship of that to a CAT scan that was done a week ago or a month ago. It's that fusion of imaging technologies that I think is very important. And then that fusion of technologies also provides an opportunity to limit radiation,
right,
because the radiation exposure in these hybrid ORs is very, very high.
It's interesting. So you're really talking, I mean, I think the whole concept of a hybrid OR is a relatively new concept, and did it come about, you think, primarily because of advances in percutaneous technology, or was it something that the surgeon was thinking about already?
I think it came about entirely because of the advances in percutaneous technology, and then it became useful in really three different arenas. One arena has to do with hybrid revascularization, where the surgeon might do a bypass, and then there might be an evaluation of that bypass immediately in the hybrid OR, and there might be supplementation of that bypass with a stent or an angioplasty. And then the other area has to do with treatment of aneurysms of the thoracic aorta, where there's a natural symbiosis between surgical techniques and percutaneous techniques. And we can sometimes limit our surgical invasiveness because of the adjuvant percutaneous techniques. And then, of course, the percutaneous valve has really created a great need for a hybrid OR. And for those procedures, we combine limited surgical access with advanced percutaneous techniques. I think it's the advent of those percutaneous techniques in those three areas that have really made the hybrid OR critically important currently.
John, that's a great description of the three sort of settings in which hybrid OR have and will play a role. Do you see this? You know, when people get into talking about needing a hybrid OR, or needing two, or needing three, people think about the cost in hospital settings today. But is a hybrid OR going to be absolutely critical, you think, to doing surgery of the future, surgical intervention procedures of the future?
I think it will be. I think it is now. And I can't imagine a major medical center that wants to do vascular and advanced cardiac procedures without a hybrid operating room.
And I agree with you. I think that's, you know, you always have to talk about, unfortunately, about economics and everything we do these days. Do you see the place where these displays that you've talked about? I think it's really neat. Is it going to be heads-up displays? In other words, where you see everything's up there and you're doing things? Is there going to be a day when people are wearing specialized visors that show things? So, you know, I'm thinking really futuristic.
Yes, I don't know too much about that, but I do know that those visors are a reality in other aspects of life and technology, and I see no reason why they wouldn't become part of medical applications. Along those lines, what I think would be an advance would be the opportunity to remove the operator from the exposure to the radiation. And I know that's just around the corner.
How do you do that? Short of you're talking about a robotic? You're talking about that concept of moving them away.
Yes, and with everything that's being done now robotically, it seems like it would be a straightforward issue to apply robotics to the advancement of catheters. Of course, you lose that feel. That feel can be critical.
Right.
But I know that there are systems in development that would advance catheters based on those heads-up images and allow the operator to be removed from the field. I'm really concerned about young people going into surgery or interventional cardiology and being exposed to these very, very long procedures for a lifetime.
No.
The other approach I think that could minimize the radiation exposure would be wider application of echocardiography.
Right.
And in doing TAVI procedures at Yale, I think what we're seeing is that, especially with 3D echo, the day may not be far away where we don't need a lot of fluoroscopy, and we can do the localization and placement of the valve largely by echo.
And there's some advances coming in echo where you can, computer-assisted advances where rapidly, within a minute, it gives you a three-dimensional model of everything. So it's really unbelievable where you can see angles and sizes of annuluses and all that stuff. It's really quite exciting. John, as you deal with cardiology and cardiac surgeons in a hybrid OR, it's really a place, as we were talking earlier, where a lot of cardiologists historically have not gone to the OR. So this concept of merging the cath lab, the OR, really creates, I think, the environment where the team concept really flourishes and we learn on the fly from each other.
I think we do learn across disciplines.
Right.
And I remember when our cardiology fellows used to come routinely to the operating room, and there'd be tremendous learning that went in both directions. We could show them anatomy, we could show them what aortic stenosis looks like in the flesh.
Actually looks like.
Yeah, and then we would learn a lot from them about interpreting our hemodynamics, interpreting our echo images, our cath images. I kind of long for that day, and I think this environment in the hybrid OR does bring our two specialties very intimately together. I do wish, though, that cardiology trainees would spend more time with us for open procedures rather than just the minimal access operations that we do in the hybrid OR.
I agree with you. As I told you, in my training, it was really almost the highlight of my training. My training was in the before angioplasty, before a lot of things, and it was spending time in the OR and getting an appreciation for what the surgeon does and what the OR setting is like. Let me finish with a question about something where I compliment you. You've made tremendous contributions in our understanding and knowledge of the thoracic aorta and diseases of that. So you brought our awareness of the pathophysiology and those sort of things. Are we going to reach the place where there can be either genetic or medical treatment of, let's say, ascending thoracic aortic and aortic root aneurysms?
I think that's really my goal, my personal goal, and I think it's incumbent on our generation to lead the way towards that end. We are trying a number of different drugs. We just published a paper that shows benefit from statins. Those statins have these pleiotropic effects,
right.
And we showed a decreased rate of rupture and dissection and an improved survival with the use of statins. But we found that kind of by accident, really.
Right.
But what we're working on very hard, and Dr. Milowitz in Texas and multiple other groups are working hard on, is to identify the etiology for thoracic aortic aneurysm at the molecular genetic level.
Right.
And advances are being made. We have an RNA signature blood test
right.
that we're excited about, and Dr. Milowitz has made great advances in identifying particular mutations. My hope is that once we understand the molecular genetics of aneurysm, then we'll know the proteins that are abnormal. And then if we know the abnormal proteins, we should be able to design conventional drugs. I'm not even talking about genetic manipulation, but using the genetics as a guide to the proteins that need to be strengthened in order to prevent this disease.
That's fabulous. Well, listen, I appreciate you spending the time talking to us about the hybrid OR. You've given me good insight, and I know you've given our viewers insight, and certainly appreciate your aortic work. Thanks very much.
Thank you, Randy. Thank you for the opportunity.
Thank you.